We're here with one of our participants of the Info editorial board and two other physicians to talk about resident fellow relations. Joining us tonight, we have Carolyn Pan, who's a second-year retina fellow at UCLA, Samantha Williamson, who's a second-year resident at Vanderbilt University, and then James Chelness, who's a second-year resident at the University of Buffalo and a member of the Info editorial board. And Info is the American Academy of Ophthalmology's newsletter for young ophthalmologists. Thank you.
Thanks, Christy. So, welcome Samantha and Carolyn to this sort of first ever for the YO, this Google Hangout that we're hosting to speak about resident and fellow interactions. And I'm glad we have a resident and a fellow here just to talk about their own histories. And Carolyn, you'll be able to give us sort of both points of views. So why don't you just tell us exactly which program you're from, how many residents are there, and how many fellows, and so on. So we just get a context for where everyone is coming from. Carolyn, do you want to give us that first?
Sure. Okay, so I'm at UCLA doing my surgical retina fellowship. There are 2 of us per year, so there's 4 total. And at UCLA, there are 8 residents a year, so 24 residents total. They cover 5 hospitals. And the retina fellows were the only fellows who also cover all 5 hospitals. So we work the most with the residents in terms of interaction, staffing surgical cases, and clinics.
Great. Thank you. And Samantha, where are you now?
Sure. So I'm at Vanderbilt, and we have 5 residents a year, so 15 total. And we have a fellowship in retina, plastics, and pediatrics. So we work with those fellows as residents.
Great. Okay, so I guess you may all be familiar now with Dr. Jung's article. Dr. Jung is the actually program director at Buffalo as well, who wrote on the interactions between residents and fellows and the types of interactions that exist, and also what it could be the possible benefits of having both levels of trainees together in one setting. Samantha, do you want to talk about a little bit of what your interactions have been, being that you have fellows available to you in different sections of your ophthalmology department?
Sure. So the retina fellows we work with in clinic, and then they staff our VA retina specialty day. So we work pretty closely with them, especially at the VA, and they supervise lasers and injections. And as a 3rd year, you operate with them and an attending once a week. Our pediatrics fellow staffs all our pediatric consults, so we cover a pediatrics hospital. And then our plastics fellow staffs all our kind of off-hours consults, and we operate with her at the VA as well on plastics cases.
Okay, great. So it sounds like you have a variety of different scenarios where you're exposed to fellows in clinic, after hours, in the OR, and so on.
Sure.
And how do you feel about how that's changed your experience in Nashville?
I think the departments that we have fellows in, it's really augmented my experience. I think that, particularly in retina, where we work closely with them at the VA, and they really teach us a lot about lasers and injections. They just serve as a kind of unique level between resident and fellow. And I think because they kind of more recently learned techniques and surgical procedures, they're able, I think, sometimes to better remember the steps of learning. So I've really enjoyed having them in all the departments that we have fellows in.
So it sounds like they're a good bridge for you guys in your training. And Carolyn, can you speak to, since you seem to be pretty involved with the residents over at UCLA, can you speak to your experience working with them? What are the scenarios in which you get to work together?
Sure. So the UCLA program is kind of split up into Jewel Stein and then the county hospitals. So at Jewel Stein, in the retina division, they're with the attending clinics, it's mostly a private practice type setting. And there's always a fellow with the attendings, but there's not necessarily a resident. When there is a resident, the resident kind of acts like a medical student, so the fellow does everything and the resident kind of shadows. And we serve as a bridge between the attending and the resident. It's much more hierarchical at dual sign than it was at my residency program. So it was kind of a unique situation for me to be in when I first started. I work with the residents the most, however, at the VA hospital and at the 2 counties that we cover. We cover Harbor County and Olive County. And there, once or twice a week, depending on the schedule, we have retina clinic and retina OR day. And there we are the attending. There is officially an attending around, but since we have attending privileges, we serve as the acting retina attending for both clinic and the cases. During the case, we sometimes have an attending, but most of the time we're just on our own with the third-year resident holding our OBI-lens or just in the biome for us. During scheduled cases, usually the retina fellow does most of the surgery. If there are any combo cases, phaco-vitrectomies, we obviously staff the residents on phacos. And if there's any extra OR time, we staff their glaucoma cases, their retina cases, their cataracts, whatever they want to add on. We're happy to be their attenders and to staff them on that. After hours, it's just the first or second year resident with us on call. And those who are interested in retina, I've definitely tried to hand over more of the surgeries. Probably not starting them off with vitrectomies right off the bat, but scleral buckles, I try to let them do several key steps like applying cryotherapy, helping place sutures, and a lot of them don't have the microsurgical skills. So this is the first time they're actually suturing on an eye that's not a pig eye or a cow eye. So it's been a really fun experience. It's hard to, even though I'm eversh out of residency, it's hard to think about what it was like when I was a first year and I didn't know my hands were under the microscope, where I was, what I was doing. Everything was just out of focus. And seeing the residents and seeing them struggle and then remembering how it was for me, reminds me that we all came from pretty humble roots. And I try to help them navigate some of the challenges I had when I was a first, second year resident.
And how do you think they? Well, let's introduce Evan, I believe, who just joined us.
Yeah,
right?
thank you, James.
Sure.
Yeah, so I can unmute this. Good evening, y'all. Hey, Evan Schoenberg here. I'm a third-year resident at Tulane University in New Orleans, Louisiana.
Great.
We're so glad you could join us.
Yeah, I'm James Chalice. I'm from the Info editorial board. I'm a second-year resident at Buffalo, where we have 3 a year. And then we have Samantha from Nashville, who's at Vanderbilt, and there are 5 residents a year. She's also a second year. And Carolyn from UCLA, who's in her second year of her surgical retina fellowship.
At Tulane, we have 5 a year as well. We have a glaucoma fellow and 2 cornea fellows, and retina fellows is sort of intermittent.
Okay. And then maybe you can sort of speak to your experiences also, just give us a little background in terms of maybe what you think are the benefits to your training and education that have existed because fellows have existed, and also possibly, how you think that the training could have been improved, or if your access to attendings is hindered in some way.
Yeah, sure. So I think overall having fellows involved in the residency is a good thing, because you get this sort of bridge between your own novice experience and the much more senior experience of attending. Because I think someone else was alluding to being a bit closer to residency can give you some of those insights about what needs to be communicated and what tips might need to be shared that maybe someone who's been doing it for a long time feels like it's just so natural they don't even think to mention it. So I definitely have overall enjoyed working with fellows. At the same time, I think programs need to do a good job demarcating not just here are complicated fellow cases and here are straightforward resident cases, but here are bridge cases, and working on those early in the year. Otherwise, there becomes an inclination throughout the year until maybe in late months to push the most complicated cases onto fellows, and then you get this negative situation in which residents aren't really challenged because the fellows are there until later on. And obviously, the challenging cases in July through the first couple months of the year, they're great things for the patients, for the fellows to be there. There's trainees who have more experience doing them, but I think that I'd encourage program directors who are thinking about how do we interact with fellows to try to do a graduated approach to bringing more and more complicated cases, maybe staffed by fellows, into the purview of residents.
Mm-hmm. So it sounds like overall we're all hitting on the this point where just because the growth of knowledge and understanding is so exponential year to year, that the fellow definitely has so much more to offer, to a resident in terms of training. But at the same time, they're a good bridge that they're so close to us, that to residents, that they have that relationship that may be harder to strike with an attending, especially early on. But definitely there is that transition, which is constant in medicine as new trainees come into academic programs, and I'm sure that's always a struggle. What case do you start handing off to a resident versus a fellow, and so on? Can you guys speak to what other let's talk about other roles that residents and fellows play together. For example, in research, have you guys participated in any research projects, and have residents or fellows helped round those experiences out? Does anyone have something that they want to say? We'll go with maybe Carolyn first, since you're the fellow. Let's start from the top.
Sure.
Yeah.
So at our department, if the resident wants to do any research, like I said, we serve as the bridge between the resident and the attending. So they usually ask us first what projects we have going on, and then also which attendings may be the right one for them to talk to for their interests. So we kind of guide them that way. And for most of the projects that the residents are involved in, there's always a fellow as kind of an advisor. The resident is always going to be first author if it's their project, but the fellow is usually second author. And we help with the methods and helping them go through charts. If it's a retrospective chart review, if it's something prospective, we help them with the IRB and kind of guide them through that process, because unless you've done it once before, it can seem very daunting. A lot of it's administrative work that once you've done it, it's no big deal. But the first time, I remember as a resident and as a med student, going through that kind of stuff and really relying on the residents and fellows to help me there. So that's how the fellows, at least at UCLA, we are always involved on a research project with the residents. And we also, once it gets to manuscript, we serve as the first edit. And we definitely do many passes before we finally submit it to the attending for their final approval.
Has anyone else had similar or different experiences that they want to share? I know that I've been involved with a number of research projects, and in Buffalo we have a cornea fellowship, and I'm not going to cornea, but so I haven't worked with them individually, but I know that the cornea section in our department is pretty heavy in research, and there's a lot of go in between the fellow and the residents who are interested. Have any of you do any of you think that the presence or absence of fellows affected your residency match lists when you were looking for a spot as a resident? Samantha, do you have any feelings about that?
I would say, I didn't set out to go to a program that had or didn't have fellows necessarily, but I think typically if a program has fellows, then that department is generally has good depth, and so I think that in some sense it's a good marker if there are fellows in certain departments that that residency program is able to support fellows and residents. And I think now being in residency, I see it as a plus. I mean, I think you probably have to talk to residents and talk, when you're interviewing and find out kind of what the balance is at that individual program. But I think in general it's a sign that departments can support fellows is a good thing.
I'm inclined to agree. I think that it's a good marker. I think it's a conversation you need to have early with fellows to get them on your team, and it can be a really valuable part of the experience. It's something I'd suggested to first-year residents coming in is say, hey, don't just start talking to the attendings, talk to the fellows, make sure that they're going to help you get the cases you're looking for. And in that regard, I think they can be a big asset, absolutely.
Mm-hmm. And it sounds like, Carolyn, you were mentioning how in your program the divide or the way they've gotten around channeling all the cases one way or another is by the location that the cases are presented in. So
yeah, exactly.
County hospitals, county hospitals, I guess, more typically will be served more by residents than not, or VA hospitals and so on. Yeah,
exactly. I think that's at least my experience from my residency and fellowship now. I think maybe nationwide that's the case. Usually the VA and county hospitals, the residents have a lot more autonomy. And then at the university, where there are more private patients, that's a good time to learn and to see how attendings do things. And I think once you've been out in the counties and you go back to the university, and you're watching the second time around, you learn a lot more since you've tried it yourself once and maybe not succeeded.
Right. Yeah, opportunity to gain some confidence in what you're doing and not be so afraid of, creating a blooper reel in one way or another. And do you feel, Carolyn, that the residents make your day longer or shorter?
Oh, definitely shorter, for sure. Yeah, I have nothing but great things to say about my residents. Anything I don't know how to do when it comes to the ins and outs of the hospital, admitting a patient, ordering intravitreal antibiotics, scheduling surgeries. Since we have 5 hospitals, and all 5 hospitals have different computer systems, charts, the residents, they know it all. And they can all speak fluent Spanish for me with our county patients. And since we're only there once a week, if I operate in them, I rely on them to see my post-op day 1 patients. And they definitely, take it seriously because they're involved in the case. They call me right away, give me updates. And without them, I don't think I would be able to survive fellowship. So it's definitely a symbiotic relationship.
Right. And I guess we'll go back to Evan. Do you get a lot of feedback from your fellows? How is that balance struck between feedback between your attendings, fellows, and are there ways in which a fellow's feedback is even more valuable than attendings in certain cases?
It can be. Our structure is a little bit different. Our county hospital is about 3/4 staffed by the fellows. So actually, part of the time we have an attending physician who actually serves in one of our private hospitals as well, but our clinic surgery days will often have fellows who are staffing there. And at the other sites where we operate as third years, we really don't cross paths with the fellows that much. So, in the county hospital setting, certainly that feedback has come very, very constructively and been useful. I think with that same thing that Carolyn was talking about it being a bridge situation. They know the sort of feedback that can be valuable. I think that it's overall it's a useful communication. And
do you guys have the opportunity, for the residents anyway, to offer feedback to the fellows? Is it a two-way street?
In the same way that any colleagues can offer feedback when there's a bit of a power dynamic sometimes.
Right.
Depends on your personality and willingness to offer feedback, I'd say.
Right.
I don't think we explicitly give feedback. I think it's part of kind of program evaluations and how the fellows affect their experience, the positive, negative, where is it a drawback, where is it an advantage, things like that. But I don't give feedback kind of one-on-one on my fellows.
Yeah.
James, if I can, sorry, we just have a question from Janice who's watching. And she says, if a program does not have a fellow in a certain subspecialty, does it make it harder as a resident to match into that specialty?
I think as long as there's faculty there who are reasonably well known, The answer to that is not only does it not make it harder, it may make it easier because you're going to have a lot greater chances to do the more complicated cases in that field. On the other hand, it's just like Samantha was saying about it being a marker. A lot of times the faculty are going to recruit a fellow and be well known in sort of a virtuous cycle of publishing and being involved, and they may be better known that way. So I think if you're really gung-ho for cornea and you're looking at a program that doesn't have a cornea fellow, you want to make sure there's cornea faculty there to support your efforts.
Mm-hmm. Yeah, I'll say in my own personal instance, definitely helped having faculty with to whom I had direct access, and working with them very more intimately, probably. In my case, have a plastics attending who is pretty well known, and very lets the trainees sort of lead the way in terms of their own development, and if they're interested in research, and is always there to accept people into the OR if they're free for an extra case or two at the end of the day. So that access is valuable, sure. And what about the difference between hierarchical versus more informal structures? Samantha, can you speak to your program? Is it hierarchical, or is it more informal, the interactions you have with the fellows?
I would say my interaction with fellows is, they're certainly above me in training, but it's pretty casual. And I think that's because we work with them both at our more private setting and then in the VA hospital. So we're pretty friendly with our fellows. So I feel very comfortable around them. I think that when we do work with them and the attendings in the private setting, for instance, in retina, we do that. So we operate in attending a fellow and a resident, and that tends to be, slightly more hierarchical or formal. But in general, I would say, we feel as residents very comfortable with the fellows, calling them, asking them for advice, and then they go to the wet lab with us. So I think our relationship with them is one of a, mentor-mentee, but in a very relaxed way.
Can anyone speak to how either exposure to fellows or, Carol, in your case, being a fellow, has that changed your mind in terms of what career you want to lead in terms of being academic versus private? Has it affected your decision-making in any way for the future?
For me personally, definitely, I think it has. I've been fortunate since medical school to have great mentors. So as a medical student, I had great residents who guided me in ophthalmology, and as a resident, and fellows who guided me and inspired me to go into retina. And since I'm graduating this year, I've taken a position in academics. I'll be joining the faculty at Stanford University in August.
Congratulations.
And thank you. But going into my fellowship and looking for jobs, I interviewed at private practices and at academic positions. And what I couldn't give up with private practice was, or what I couldn't give up in academics and going to private practice was I couldn't give up the relationships that you have. Lots of private practices, you are the only person in the office. You have your partners, but you don't really interact with them on a daily basis. And I love working with the residents and my attendings and having colleagues to just have feedback and brainstorm and discuss interesting cases with. Going to meetings, seeing now I have a big network of other fellows that I've met, residents I've done residency with, and it's just like a big social circle that keeps growing bigger and bigger and bigger. And the camaraderie you have in academics was just really appealing to me. I just couldn't imagine giving that up. You can always do that in private practice too, which is a little more difficult. And so I think because I had such great fellows as a resident and great residents as a fellow, that definitely encouraged me to continue down the academic path.
Yeah, I think referring back to Dr. Jung's article where he uses the phrase "iron sharpens iron," I think it's well said. It speaks to the fact that definitely I think we would all agree that fellows help the residents' education, but also having residents around in academic environments keeps the fellow moving forward. I think also, and expanding their horizons as well. I mean, keeping up with the most modern technologies and so on. So it is in some ways a two-way street. Does anyone else want to speak to that? What's been the most impactful experience that you've had, either as a resident with fellows or as a fellow with residents? Evan, do you want to speak to any impactful scenarios you've had, experiences?
You know, I don't really have a good story on tap, actually.
Okay.
I don't
That's
think
fair.
I can
Put you on the
answer
spot
to
there.
that in a very interesting way.
Okay.
We have another question from Janice, actually. She says, do any programs have trouble meeting their ACGME surgical numbers because fellows are operating with the attendings?
I don't think so.
The ACGME numbers aren't that hard to meet.
I think for retina it's 10 that counts surgical plus assistant, right? For you guys, right?
Yeah.
And so, sorry, but Carolyn, you were saying you don't think so?
I mean, I agree with Evan. I don't think the numbers are unreasonable. And I mean, at least for cataracts, the only people we think maybe stealing cataract surgeries would be maybe the cornea and the glaucoma fellows. But I think they also, at least at most programs, they will staff the residents on cases at their leisure too. So
I think numbers may ask the wrong question. Like I was kind of alluding to earlier. For example, in my program, I haven't done as a resident any sutured IOLs. I haven't done any iris fixated or scleral fixated IOLs because those are cases that typically go to the cornea fellow. So, personally, being that something that I was interested in getting the skills of, that's a particular avenue. Not saying that it violates ACGME numbers, but that I was unable to really acquire those skills because for the first 3 quarters of the year, they said, attending said, then that's a fellow case. That's not a resident case. Whereas at other programs where there aren't fellows, that might be by definition a resident case. Were it at the county hospital or the VA, those patients have to get taken care of one way or another. And it's not so much a matter of fellows stealing cases as the expectations of the system shifting those cases towards the fellows.
I think as we advance through our training, definitely obviously there's a seniority, but also I think there's a factor of when you're in your last year, it's sort of your last chance to approach a case, and maybe do you think that's affected the attending's choices, Evan? This is the fellow's sort of last chance to see a case.
I think it has to some extent. We lost.
Oh, I think she had to take a call. She just muted her camera for a minute.
I was trying to head
I was just confused for a moment.
Okay.
And I think that's a two-way street because, of course, the fellows, it's their last year of training. I'm going into a fellowship myself, but for some residents, it's their last year of training. So there's a balance to be struck.
That's right.
And I think that having at least some amount of exposure in a controlled environment before diving in, having to, say, watched videos or attended a course is valuable in both parts.
I'm sure that a lot of academic institutions, when they have fellows, they would like to see residents go to fellowships more often than not. But at the same time, you want it to be for the right reasons, where it's to further enrich your knowledge base and your experience rather than to catch up.
Right, absolutely. But even when you're fellowship bound, I think showing up to fellowship saying, no, I haven't done a lot of those, but I've done one, is a very different, at least in what I'm about to start my fellowship in a month. And I think if I can hit the ground, and say, yeah, let me do this case with your mentorship, don't worry, I've seen a bunch and I've done one. It's a different conversation than starting fellowship and saying, what's that? Right.
Yeah, and I think ophthalmology is definitely, though it's a hybrid field where you have a lot of clinical time, being that it's surgical, it's a experientially based field where you need to do something to really learn how to do it. So as opposed to seeing it 1 or 2 times.
I think Evan.
I mean, I know I'm the fellow here, but from my experience in residency, I feel like the fellows actually let me try things the attendings wouldn't. Attendings, you're on their OR time. If they hand over a case to you, they just want you to do it. That's way that you're comfortable, and move on to the next case. Whereas I did, my first scleral fixated sutured IOL with my fellow, my first full corneal transplant with the cornea fellow, my first PPV core vitrectomy with the fellow. So, I mean, because I've had great fellows who've trained me, then I try to do the same for my residents. But I definitely think it's, very individual to your experience and who your fellow is, who your trainings are, where you trained. Every single institute is different.
Yeah. Yeah. I think definitely the ones that are, when people in general in your, whether it be attendings or fellows or residents, are just more interested in teaching and handing down knowledge, whether it's from a PGY3 to PGY2 or a fellow to a resident, definitely that creates a huge impact in terms of what they can offer. And have any of you had experiences like that where your access has been enriched by the fellow being present?
I'll go ahead and answer that. I'll answer that too, because I don't want to sound like I was being fully negative about it. Just like Carolyn, my first PK was with a fellow, and my first core vitrectomy was with a fellow. Those moments, I agree, where you get a chance to push a little bit and to learn a lot.
Definitely.
And I agree that fellows seem to have a different, they have a different schedule, different sense of timing. So I think your relationship with them in the OR is very different than your relationship with an attending in the OR. And each has their advantages, but I think it would be a loss if you didn't operate with fellows as well.
I think we were alluding earlier to the fact that fellows obviously are newer to the knowledge and experience they've gained than attendings, and they are more likely to remember the shoes that residents are in, and it's being that they were there only a year or two ago, and maybe that it makes it also more rewarding of a teaching experience, because you're closer to it, everything, what the other person is going through freshly in your mind. So are there any other thoughts about fellow or resident interactions that anyone wants to share?
I would say one thing that I really like is getting a sense of what other programs are like for my fellows, kind of the way different ways they did things, how their residencies were run, their experiences. I think that's always interesting to hear, because otherwise, you really only do one residency, so you're familiar with the way your institution works. So I've really liked kind of hearing about my fellows' experience as residents at different institutions.
Definitely. Thank you. Christy, I don't know if you wanted to make some remarks or.
Yeah, well, I think in respect of everyone's time, maybe we can wrap it up. But thank you all so much for being part of this conversation. And we'll have a related article posted on Monday in the YO section of the American Academy of Ophthalmology website. You can find it at www.aao.org/YO, and we post new content every month. So look for the email in your inbox or find us online. Thanks so much, everyone.
Thank you.
Yeah, thank you, everyone, for participating.
Thank you.
Okay. Have a great night.